Hello students, I am Dr. G. Rajkumar, Professor from Department of Prosthodontics at Veneers Shankaracharya Dental College. Today I will be covering the topic of veneers, which will be covered as two parts. Today will be my first part. So going on to the content of today's presentation, I will be talking about the introduction, I will be talking about the definitions, what are all the types of veneers, indications of veneers, the contraindications of veneers, advantage of veneers, disadvantages of veneers, and determinations of essentials, pre-treatment evaluations, aesthetic pre-evaluation, evaluative temporaries, objectives of preparation, and the types of preparation. Till this I will be covering it today, and in the second part I will be talking in elaborate about the armamentarium and how the preparation has to be done. So we will start with the presentation today. So to have an introduction, so nowadays you all know that aesthetic dentistry is going to be the prime player, and which is going to be a very important concept which has been taken by the patients. So aesthetic dentistry is an upcoming field, and which has to be, it's going to be a combination of the art and science. So if the art and science are clubbed together in a proper proportion, then you are going to have a very successful treatment and end result. So before going into what is this aesthetic dentistry and what is this veneer and all these things, you should understand what is the difference between the art and the science. So science is nothing but mechanics, that is a step-by-step protocol what has to be done in an order. Whereas the art is what we do, that is a skill set of our hands, that is our dentistry. How efficient are we delivering the protocol which is supposed to be done from our dentist side. So coming to the definition, according to GPT-9, I think you will be knowing what is GPT. GPT is nothing but glossary of prosthodontic terminologies, right? So according to GPT-9, that veneers in the year 1702, they have said a thin sheet of material used as a finish. Second, it is also called as a protective or an ornamental facing. And thirdly, it can be also defined as a superficial or attractive display in multiple layers, frequently termed as laminate veneers. Okay, this laminate veneers is a very common interchange between the veneers and laminate veneers. So we should understand both these terminologies goes hand in hand with each other. Okay, this is according to GPT-9. So coming to the definition as it is, to have a better understanding in the field of prosthodontics or in the field of dentistry, we need to understand what is a veneer. So it is simply explained as the layer of tooth colored material that is applied to a tooth for essentially restoring localized or generalized defect or intrinsic discoloration. So these 3 points, right? These 3 points are very important thing to be understood when we do a veneering, right? So coming to the types of veneers. When you see the types of veneers, we have two types of veneers. One is going to be the partial veneers. So as the name implies, or it is a self-explanatory kind of thing, which indicates it's going to be a partial part of the replacement. That is, if you have any localized defect or some minute area of discoloration on the tooth surface. So if the patient needs a masking or correction of that localized defect, you create or you change only, or you add only that part or replace that part alone without involving the rest of the other tooth. So this kind of veneers are called as partial veneers, right? And coming to the next type of veneer is called as a full veneer. So So as the name, as I told you, it's going to be a full veneer. So where you are going to involve the entire tooth surface. So the entire labial surface of your tooth is going to be involved in replacing or correcting the defect or masking your discoloration or any alteration which is needed for the particular tooth surface. So this is the types of veneer based on the amount of replacement what you are going to give, right. Coming to the types of veneer based on the fabricating technique. So when you do the fabrication, as you know, in conservative dentistry also they do a laminate veneers. So that kind of veneers are called as direct veneers. That is, you do it on the chair side, that is your composite veneering. Okay, we have indirect composite veneering also, but the direct veneering is the kind of veneering which is done directly on the patient's mouth on the chair side or on the clinical aspect, right. So that kind of veneers are called as direct veneering. So the second type is called as indirect veneering. As the name it's understood, right. So indirect veneering is which kind of veneers which are done outside the patient mouth. You make an impression, you pour the cast, or you do a digital impression, you digitally mock up, or all this thing is done outside the patient mouth. So it is not going to take much of your chair side time. So you make your impressions in the patient, you do all the procedures in your laboratory, and then you do your final processes, and then you call the patient, you fix it. So this is called as indirect veneering. When you see the difference between a direct veneering and indirect veneering, the indirect veneering has much more mileage or advantage when compared to your direct veneers. What are they? The first one is it's less technique sensitive. So the mistakes what you do can be manipulated or can be corrected in an indirect, because in direct veneering you are going to do it right on the patient's mouth. So it's very difficult to correct it once the process is going on. So that is going to be the first advantage. Second is more aesthetic. So how much ever we are capable of doing a direct veneering, so there is always a human error involved in the process. So it can be minor error, but still when compared to the indirect veneering, so even this minor error also can be corrected in an indirect veneering. So the aesthetic result is going to be much better. So I don't say that direct veneering is not aesthetic. It has aesthetic also when your hands are good, but still the indirect veneering has a more advantage in having all the technique sensitivity, less technique sensitivity, more aesthetic result also can be obtained. And the third advantage is going to be long lasting. So the indirect veneering is can be done with composites, can be done with your porcelains. Okay, so all this thing is going to be lab procedure, lab composite, and the porcelains are going to be much more stronger material which has more abrasive resistance and more other advantages when compared to your direct composite veneers. So the lasting or the life expectancy of your indirect veneering is much more higher when compared to that of your direct veneering. And the last and one of the very important thing in your indirect veneering advantage is the multiple tooth can be done with a indirect veneering. I don't say that direct veneering multiple tooth cannot be done, but the advantage in your indirect veneering for a multiple teeth is that the chat time which is needed for one veneering and or it can be a multiple veneering, the time consumed, chat time consumed in your indirect veneering is all the same. Whereas in direct veneering, for example, if you take 15 minutes for one tooth to be veneered, if you are going to do it as a 6 unit, then calculate how much of time it is needed. The patient has to be seated, the patient has to spend his time in your clinic, the dentist has to involve himself, the concentration point and lot of other factors are going to be there. So whereas in your indirect veneering, you make your impression, you send it to the lab, how much ever time is needed, the ample time is there in your laboratory, you can modify, you can alter, we can check, everything is possible when you have a multiple tooth involved in a replacement. So indirect veneering has all these advantages when compared to your direct veneering. Okay. Coming to the indications of veneering. So this is going to be one of the interesting thing. The veneers, lot of veneers has been done nowadays. So the first indication is going to be closing of spaces. So you can see here, so the patient has a midline diastema. Again you have to understand the large midline diastemas cannot be corrected with your veneering. So the veneering has its own limitations and the material what you use also. So closing of space, that is mild midline diastemas, can be corrected, and so this is going to be the pre-op, whereas this is going to be the post-op. Can you see the amount of correction what has been done here? Okay, so the first indication for your veneering is going to be closing of spaces, and second indication is lengthening or short or worn out teeth, that is to improve the tooth shape. Here again in this picture you can see the amount of tooth exposure is going to be minimal, whereas for this particular patient you need, if the patient is expecting to have a much more longer tooth, then it can be corrected. Okay, so the second indication is lengthening or worn out teeth, the improving of your tooth shape, that is going to be the second thing indication. And the third indication is minor tooth position improvement, that is correction or rotation or overlapping, correcting the rotation or overlapping of your malposed tooth. Here you can see there is going to be a mild rotation of your central incisor, whereas this can be corrected with the help of your veneers. You can see here you are going to have the corrected thing. So all this thing is, the veneers cannot do a miracle. So it's going to be a mild corrections of your malalignment, and the other indication is going to be making aged tooth look youthful. So that is the aesthetic point. In some countries this is becoming very famous and they call it as Bollywood smile or Hollywood smile. So you recreate the designing, or you recreate the smile design, or change the smile pattern of your patient, the exposure of the tooth, so that the patient looks much more youthful when compared to the regular aspect. Okay, the next indications is correcting the tooth in lingual version. Again, this is going to be, we cannot say that lingual version means it's going to be a crossbite, if it is going to be a end-on relation. So in that situation, the mild lingual version of your tooth malpose positions can be corrected with that of your veneers. Okay, next is going to be post-orthodontic treatment. Again you can expect, or you can say why orthodontic treatment has been done and why again you need to do a veneering. So in the orthodontic treatment, in some situations we need to have little bit of the correction cannot be done at some situations. It's not always that it cannot be done, but in some situations the mild correction rectification can be done with the help of your post-orthodontic, with the help of your veneers. Okay, post-orthodontic mild corrections can be done. And the last one is going to be your shade change, that is your brightening of the shade or stain correction. So here you can see the patient has a tetracyclic stains. Okay, so this tetracyclic stains can be altered, and then you can give a uniform shading which the patient prefers. Either it can be a bright smile or it can be a mild alteration. So most of the patient doesn't like the very bright smile, right? If the patient has a slight darkening, and the next day when the patient do the correction and go in front of the patient with a very bright teeth, will it look nice? So in that situation the patient or the dentist, as a doctors, we should advise him that 1 or 2 downgrading or upgrading of the shade can be done, and not to the extreme, so that it becomes more of artificial. The main aim of the aesthetic dentistry is that not to make it more obvious, show that it doesn't look more artistic, and it should be more of natural than your artistic effect, right? So these are all the indications of your veneer. And coming to the contraindication, when there is an indication, always there is going to be some contraindications. So contraindication, the main contraindication is going to be discoloration leading to deep dentinal defect. This is a very important thing you should understand. So when your defect has reached the dentin, then that area or that tooth is not an ideal tooth for replacing your veneers. So veneers always are a resin bonding mechanism. It has the bonding between your natural tooth and your veneer is going to be via a resin cement. So the resin, as you know, the resin has a better bonding to the enamel rather than a dentin. So when your discoloration has been deep into the dentinal area, or the defect of your enamel is in such a way that it is encroaching into the dentinal space, then your veneering should be abandoned. Okay. So that is going to be your first contraindication. And next is the same thing, the enamel defect. If you have an enamel defect, then your bonding is going to come down, the retention of your veneering is going to be less. So enamel defect is going to be the second contraindication for your veneering. And third one is large diastema. As I told you, the large diastema, it is very difficult to correct large diastema with the help of the veneering, because when you have a large diastema, you need to increase the size of your crown. So if you are going to increase the size of your crown, you are going to change the proportion of your face. So in that situation, either you have to correct it, or you take the adjacent tooth support and then make it as canine to canine veneering, or it has to be converted as a root canal treated, and then the mock-up has to be done, and then you divide the space according to the proportion and then go for a full crowning. So the veneering cannot be done or should not be done in a large diastema, which is going to end up in a broader or wider teeth, which is going to give an unnatural or unaesthetic appearance. Okay. So next is severely malposed teeth. Again, the malposed teeth, you cannot expect veneer can rectify all these malposed teeth positions. So this has to be first corrected with an orthodontic treatment, and then after the orthodontic treatment, mild variations in the spacing or malpositions can be corrected by a veneer. So that is going to be the next contraindication. Severe malposed teeth should not be taken up for your veneering, because it will create lot of occlusal disturbances, or the protrusive and lateral balancing will not be achieved. So you are going to end up in failure of your veneers. Okay. Next contraindication is poor restoration on the labial surface. If the patient has already done a restoration on your labial aspect, and if that restoration is going to be a very poor restoration, then either you have to go for a full crown, or the entire restoration has to be removed, redo the restoration, and then go for your veneering. So poor restoration, if you encounter or if you see a poor restoration when you decide for a veneering, better do a re-restoration if it is possible, and then go for your veneering. If not, the poor restoration on your labial surface is absolute contraindication for your veneering. And next is the aging. So as you all know, as the age advances, the enamel is going to thin out. So if the enamel is going to thin out, the amount of surface area or the bonding between your resin and your in between the veneer and the tooth is going to come down. So the wearing pattern, that is aging, is going to create less or thinning out of your enamel. If the enamel is going to thin out, over which if you are going to do a preparation, and then again it is going to end up into the dentinal space or dentinal area, which is going to bring down the bonding strength of your resin. So if in a very old patient, veneering is not advisable. Okay. Next, the same thing, available of enamel. If it is going to be a question mark, if you think that the amount of enamel is not sufficient for doing a good bonding for your veneers, then never think of veneers. So in that situation, you have multiple options for better restorations. So questionability of enamel is going to be how much of ability the enamel can have, or the bonding between the enamel and your resin and your veneer is going to have. So in that situation, if the enamel is deficient, never try a veneering, because enamel is going to be, I will be talking about why this enamel, I am talking about this enamel, everywhere the enamel, if the enamel is less, if the enamel is deficient, if the enamel is this and that. So I will be talking about why this enamel is very important in your veneers. Okay. So next is oral habits. So if the patient is going to have oral habits, like some patient, it's an occupational hazard or occupational habit also. So the you can see the holding the nail with your anterior tooth and then do the thing, because for every time they will not be able to pick up the nail, and so some patients will be having biting the nail one by one, and they will be doing the work. So that kind of habits is going to be a contraindication. Similarly, the bruxism, that is going to be a very common thing. Bruxism is going to create lot of unwanted forces either on the protrusive or on the laterotrusive. So in that situation, oral habits are going to be a absolute contraindication for your veneerings. Coming to the advantages of veneers. So first one is color. So whatever color we need can be brought or can be developed with the help of the veneer. If you want a multi-coloring, so multi-coloring, I am not asking you say that it's going to be red, blue and white multicolor. It's not multi-coloring. You have the layering of tooth, right? Dentin has a yellow shade, whereas the enamel has a white shade. So if we need a more aesthetic appearance, sometimes due to the aging effect, as I told you, enamel is going to thin out, and the dentin is going to have a upper hand and the teeth appears little bit of yellowish. So in that situation, if the patient is little bit mid-aged patient, around 50, you consider as the patient is at 50, you cannot give a very bright white appearance for your restoration. So in that situation, you have to give a mild discoloration or mild yellowish tinge on your cervical aspect, so it gives a more aesthetic appearance. So that color variability can be an advantage in your veneers. And the bond strength, again the second thing is bond strength. The resin cements have a better bonding on an enamel than your dentinal aspect. So whereas in your direct veneering, you need the preparation is controlling of the preparation has to be very accurate, so the bonding strength has to be maintained, whereas here the bonding strength can be achieved better in your porcelain versus your tooth rather than your composite versus tooth. And periodontal health. So how this periodontal health is going to be important or advantage in your veneers. So the first thing is, in your veneers always your preparation has to be supragingival. So never ever try to take it subgingival, at least at the level of your gingiva, not subgingival. So your periodontal health will not be compromised in your veneers preparation or veneer placement. And next is resistance to abrasion. As you all know, from here onwards I will be talking more about the indirect veneer rather than the direct veneers. So all these advantages, disadvantages will be more pertaining to that of your indirect veneering, that is your lab fabricated veneer, prosthodontically driven veneers. Okay. So resistance to abrasion, because if you want to use material like lithium disilicate, it's more of aesthetic value, has more of aesthetic value. Zirconia with layering, all this thing is going to be a ceramic part which is going to have more resistance to the abrasion when compared to that of your indirect composite veneering or direct composite veneering. So, resistance to fluid absorption, again the ceramic ceramic does not absorb water, so it has a more resistance. So, the life longevity is going to be more. When you achieve all these things, automatically the aesthetic is going to be much more better, because you are going to do it on the laboratory aspect. So, it can be laboratory fabricated. If needed, you can have a try-in on the patient, and if the correction is needed, it can be taken out again. You can do all the corrections which is needed, and then again you can do the firing, glazing and everything, and then the correction is much more easier when compared to that of your direct veneering, because in direct veneering it is very difficult to achieve or do the corrections on a go. Okay. So, the aesthetic value in your indirect retainer is much more higher, which is, as I told you, it is going to be the advantage of your veneering. So, as I told you previously, when you have an indication, you have a contraindication. Similarly, when you have an advantage, there is also certain disadvantages when you do the veneers. So, when we see the disadvantages of veneer, the first one is repair difficulty. The repairing of your veneer is, I cannot say, I do not say that it is not possible, but it is going to be difficult, right. Removing of your veneer is really an Herculean task, right. So, removing the bonding between your veneer and your enamel is going to be much more higher. So, retrieving of your restoration is very difficult. So, in that situation, either you have to trim it and then you have to do a refabrication of your restoration, or you have certain materials nowadays available, repair kit we call it as a laminate repair kits, which can be used, but still the final result will be little bit compromised when you compare to the original restoration. Okay, that is going to be the disadvantage. And next is technique sensitivity. Obviously, the technique is cumbersome. All your prosthodontic procedures, when you do, it's going to be a cumbersome procedure. So, when compared to the rest of the restorations, the veneer is more technique sensitive, because you have to achieve the restoration. The thickness is going to be 0.3 to 0.5. That is going to be the maximum reduction what you are going to do in your natural tooth. So, the restoration also has to be within that limitation, that is 0.3 to 0.5 is the more acceptable thickness for your restoration. So, you are going to handle a very sensitive restoration. So, the technique involved also is going to be technique sensitive. It is going to be very sensitive, because it involves the smile correction. The smile is what the patient expects whenever the patient comes to your clinic. The first thing the patient expects from you is not the functionality, first is the aesthetic. So, whenever you do the restoration and give a mirror to the patient will not look into the function, how it is going to be. The first the patient will open the mouth, look into the mirror, see how beautiful the patient appears. So, the aesthetic is the primary concern for the patient. So, when the technique is sensitive, because the aesthetic result what you are going to give for the patient is of primary importance. So, the sensitivity in your technique also increases, because the pressure on you during the fabrication is going to be much more higher when compared to the other restorations, right. So, next is tooth preparation required. So, obviously, when you do conservative preparation, that is well and fine, but still the preparation has to be done. You are going to damage your natural tooth. So, that is always a disadvantage. You are going to damage the natural tooth. So, permanently the patient has to have the veneers. If this veneer is going to fail after a 15 or 20 years time, then the second veneer has to be replaced, because already you have done a damage to the enamel, you cannot leave the enamel damage. So, you have to redo the thing. So it's not a conservative management, it's going to be a destructive management. So that is going to be the one of the disadvantage. But still, when compared to the aesthetic result, this is not much of the concern, but still the tooth preparation has to be done, which is considered as disadvantage for your veneers. Okay. And next is extremely fragile and difficult to manipulate. As I told you, you are going to deal with the emotion of your patient, and that is the aesthetic value what you are going to give for your patient. So which is going to be more concern on to the patient, and the patient, you have to satisfy the patient. That is very important in your profession. As a smile designer, as a dentist, aesthetic dentist, you need to satisfy the patient which is coming to you believing your efficiency. So as I told you, it's going to be fragile because 0.3 mm is going to be the thickness of your veneer, 0.3 to 0.5. So the lithium disilicate, again, that's going to be a very thin glass material. So if you're going to press it with your finger, it's going to break out. So that's going to be a very fragile. You have to handle it very efficiently, and the borders has to be achieved properly. The seating of your restoration, the cementation of your restoration veneers is going to be a very technique sensitive, and you have to have a real expertise when you do the cementation of your veneer. You are not supposed to overlap it, you are not supposed to allow the excess cement to leach into the adjacent tooth, because when you allow the cement to leach into the adjacent tooth area, the next veneer is not going to fit into the position. So all this thing is very technique sensitive, and it is very difficult to manipulate. That is going to be the disadvantage of your veneer. And the final thing is going to be the expenses what you are going to incur for your patient. So lithium disilicate, or it can be a zirconia, certainly it's going to be a technique sensitivity. As the technique is going to be much more cumbersome and it is going to be sensitive, the amount of expense or the amount of time spent on it is going to be converted into a financial part. So the expense is going to be another disadvantage of your veneers. The next thing is determination of the essentials. So before you go into the as it is procedure, you need to evaluate certain thing when you decide about the veneers. So when the patient comes to your clinic, and you need to see what has to be done, and if you have a thought process that this patient can be given a veneers, so that in that situation you need to understand or you need to evaluate certain parameters, whether this veneering is going to give a better result for the patient, or this veneering is going to be an apt treatment option for this patient. So for that we need to evaluate the individual tooth first. What is going to be the age of the patient, whether the fracture, if the patient comes with a fracture, and if you are planning for a partial veneer, what is going to be the extent of fracture. So if it is going to be 50% fracture, then I don't advise you to go for a veneering, because the amount of surface area, the reduction in the surface area for the bonding is going to be inversely proportion for the betterment or the final result. If the amount of enamel is less, the strength, bonding strength is going to come down, so the retention for your restoration is also going to come down. Okay, the amount of fracture has to be evaluated, and the malposition of your tooth. So as I told you, if the malpositioning of your tooth is going to be much more, if it is if it has a very much the malpositions of your tooth are too gross, then you cannot plan for your veneers. So the tooth position has to be evaluated first, and then comes your gingival margin and gingiva. If the patient is going to have a high smile line, then you need to have a certain parameters has to be evaluated, how you are going to give the appearance or how you are going to change the appearance. For this we have lot of softwares which I will be talking about in next few slides, how to mimic or what can be done with the gingiva and how the gingival margins can be adjusted. So you have to evaluate the gingiva and the gingival margin. And next is going to be the occlusion. So you may think, why this occlusion? I am talking about the essential part of your determination is going to be occlusion. Anterior doesn't have occlusion, I know that, but why this occlusion is going to be an essential part? in your veneer fabrication, because if the patient is going to have a deep bite, so in that situation when the patient is going to have a protrusive movement, so the protrusive movement has an interference. Okay. So generally I will be talking about what are all the types of preparation you can encounter or you can do. So while I am talking about that, you will understand why I am talking about this occlusion. Okay. So you have to evaluate, because 75% of your unsuccessful restoration is due to occlusal interferences. If you have occlusal interferences, certainly how much ever work you have done in your laboratory or how much ever aesthetic work you have done for the patient is going to be on a wane. Okay, it is going to go for a failure, it will chip out, and again you have to do all this work again. So which is going to be a waste of time, waste of money, and everything is going to be wasted, right. So that is going to be a very important thing. And next is age of the patient, because as the age advances, as I told you, the enamel is going to thin out, the bonding between your veneers and your tooth is going to come down. So in a very old age patient, never plan for a veneers. Coming to the treatment evaluation, previously I was talking about the determinant of essentials. So these are all the essential thing you have to understand when you decide on the veneer as your treatment option. So you have decided, the patient is decided, and you have done everything. Everything is apt for that patient, and you have decided about to go for a veneer treatment. So what are all the things you have to evaluate, or what are all the things you have to look into when you plan for your veneer? First is going to be the face. So for that I recommend you to take multiple angle of photographs and video tapings, right. So photography, front view, profile view, top view, all these views will give you much more clarity or ideas about how the restoration has to be and how you can satisfy the patient. Ultimate end of the day, the result is going to be if the patient is satisfied, you are also satisfied. The job satisfaction is a much more greater than the money what you earn, right. So the face, you have to observe the face, how the face is going to look like. And if the patient is a tall patient, well built patient, then you have to assess what is going to be the amount of exposure you need for the tooth. And next is going to be the lip. What is going to be the lip line? Short lip line, length, long lip line. So how much of exposure you are going to get when the patient is going to talk, when the patient is going to smile, when the patient is going to be at rest. All these things should be evaluated. And the third point is going to be the color. So as I told you, you cannot give a very bright color restoration for a very darker patient, and it will appear like an advertisement, right, a Brilla white, and when the patient is going to open the mouth, the entire thing is going to look like a whitewashed area. So it's not an aesthetic dentistry what you do, right. You have to match the color of the patient, and then you have to give you a restoration. That is going to give you a much more aesthetic appearance than your restoration which is given blindly. If the patient is asking for a white teeth, you cannot give just white A1 shade which is going to be the brightest of all. So all these things cannot be given. So you have to estimate what is going to be the hue, what is going to be the value, and what is going to be the chroma, what is going to be the amount of translution needed at the incisal edge, and what is going to be the texture which is going to give a better appearance for your patient. All this can be evaluated when you do lot of photographies, right. The profile, front, and all this gives you a much more better idea. And the videotaping, in which way this videotaping is going to help you? When you see me, right, I have given you a lecture for nearly 40 minutes, right. So when you look at my face, how much of exposure I am going to give when I speak, when I am going to laugh, all these things cannot absorb on one single photographs, right. Multiple time you have to see and you have to analyze. So that's where the videotaping is going to give a benefit over your photography, right. So next is pre-operative evaluation. The previous thing I told you, pre-treatment evaluation. So when you decided about treatment, you have to evaluate these are all the factors. Next is pre-operative evaluation. So you have evaluated everything, the face, and you have determined these are all going to be your needed thing. So what you are going to do? You are going to evaluate what is needed for that patient. So for that you have the digital dentistry is the next upcoming field. We have softwares, a lot of softwares are available in market which will give you the exact values. Here you can see one of the software is DSD, Digital Smile Designing Software. So in that you have to take the photos from the front, from the profile, with a patient with a normal resting state, with a cheek retracted position, and all these things, multiple photographs. It will ask you in sequence what are all the things to be needed to upload into the software so that it gives you a better result. So when you load all these things, you can see all these white lines, right? So these white lines are going to be estimated or calculated value which is given by the software. So you can see here, right? It gives you, this is going to be the proportion, we call it as golden proportion. I am not going to go into the golden proportion and red proportion because that itself is going to be a different topic when we talk about the smile designing. And the smile designing as it is going to be a very huge topic. So you can evaluate what is going to be the shape, what is going to be the size, how your lip line has to be. All these things can be evaluated and you can get a mock-up. You can do everything. You can place your restoration and you can take a printout of the restoration, what you have done. Okay, this can be also showed to the patient. So, and it has a comparative screens. You can show what is going to be the previous and after your mock-up, how it is going to be. So the patient can better understand how your final restoration is going to come out. So that is going to be the advantage of digital. So after you do all this preparation or after you do all these mock-ups, the printout of your restoration can be taken. Okay, so you can ask me one thing, I don't have a digital smile designing app or all these things. What am I supposed to do? Of course, previously we did not have, 4 or 5 years back the digital dentistry was not in that much form. So what we do, you do a preparation, you do a mock preparation, and you do a mock preparation and you do a additive waxing up. So that is what we have done in the previous years. You do a mock-up. From the mock-up you do a silicone guide, as you can see here. This is still followed in the institutions, right? We ask our students to do a silicone putty indexing, and then with that you do the preparation, or much more if you need to have a better result, I will be talking what can be done in the next slide, that is called as temporaries. Okay, pre-evaluative temporaries. So additive wax up, after the additive wax up, in the additive wax up you will have the end result. In that you take a silicone guide, and then with that template you go for your preparation. So the restoration, all this evaluation, pre-operative evaluations is very important when you go for this aesthetic dentistry or aesthetic veneering. Okay, so as I told you, aesthetic pre-evaluative temporaries, we call it as APT. Okay, aesthetic pre-evaluative temporaries. So this plays a very important role in the success of your restoration. As I told you, a mock-up wax up has to be done. From the mock wax up, you make a silicone putty. From the silicone putty, you fabricate or you do a temporary. The silicone putty has to be placed into the patient mouth, and then allow the injectable composite to flow inside and get your not injectable composite. It can be a temporizing material of any kind, cool temp, pro temp, everything. We have lot of varieties. So allow the temporaries, fabricate the temporary. Okay, now you can see here you have a temporary in the patient mouth, and putting the temporary in the patient mouth, this is going to be the temporary. You place it into the patient mouth and then you do the preparation. So what is the advantage of doing this preparation over your restoration? So the temporary is going to be the thickness of your restoration, because you have done your pre-evaluative designing, digital or it can be a wax mock-up. So that is going to be the thickness of your restoration, right. So if you do the preparation over your temporaries, you remove the part which is needed only, right. For example, you can see here you have the thing is not reduced, but here you have a lot of reductions. So what does it indicate? This indicates that here the tooth was more, right. The reduction has to be more, whereas in this area the tooth would have been tilted. So in this area you need more of restorative material rather than trimming the tooth. Okay, so if you are going to trim, the thickness of your restoration is going to be more. So whereas here only 0.5, whereas here you are going to have more of material. So you are not going to unnecessarily trim the enamel. As I told you, the more the enamel you are going to have, the better is going to be your bonding between your resin and your teeth. Okay, so these APTs are very important in your veneers. So coming to the objective of preparation, so the ultimate and very important thing always I talk whenever you do a veneers is going to be preservation of enamel. So enamel is going to have a lot of benefit. So the amount of tooth reduction should never be made according to the existing tooth surface, but rather to the final volume of restoration. That is what I was mentioning you here. So the tooth preparation should not be based on the amount of reduction, it should be based on the final volume of your restoration. This is going to be the final volume of restoration. So the restoration needs only this much of preparation. So you are going to do only this much of preparation in your patient, so that you are going to preserve the enamel. So the more the enamel, more is going to be the bond strength between your enamel and the restoration. So the life of your veneers is going to be more. Okay, and second objective of your preparation is going to be aesthetic. So the ultimate aim of doing a treatment is going to be the aesthetic dentistry, because this is as I told you, this is called as Hollywood smile or Bollywood smile, whatever smile, it's all we call it as smile makeovers. You are going to change the smile of your patient. Okay, so the aesthetic value is of utmost important, and at the same time preservation of this enamel is going to be equivalently important, right. Why this enamel preparation has to be minimal? Thinner the enamel is going to get, the more the flexibility of the teeth is going to be there. You cannot observe right in your naked eyes, but still the enamel is going to be the strongest thing in your part of your teeth. The dentinous tubules, it has bending effect. So the enamel, if you are going to trim more enamel, the rigidity of your tooth is going to come down, so the flexibility is going to increase. So the restoration is also going to go for a failure at an earlier stage when compared to that of your more of enamel preparation. Okay, the strength of the bonded veneer together with the preserved enamel, existing enamel, will minimize the tooth flex and thus create a strong bond between the PLV, that is porcelain laminate veneers, and the enamel. So this is going to be the main objective of why you try to preserve your enamel. So that's going to be very important. Okay, so coming to the types of preparation, basically we have 4 types of preparation: window type of preparation, feather type of preparation, flat edge or butt joint preparation, and overlapping type of preparation. So first design, window preparation. So I will be explaining only about the types, and how you do these preparations will be dealt in the next part. Okay, so the window preparation, the main thing about this window preparation is you are going to limit your preparation before the incisal tip. Okay, this is going to be the incisal tip. So your restoration is going to be or your preparation is going to be below this, the incisal tip. This is the incisal tip. So you are not going to involve the incisal tip. So you are going to create a window kind of thing on this aspect of your labial aspect. So that's why it is called as a window type of preparation. I will be talking about what is advantage, disadvantage of all the thing when I talk about the preparation. Okay, next is a feather design. So here what you are going to do, you are going to involve the incisal tip half of the incisal tip. That is going to be a very important point you have to note here. You are going to involve half of your incisal tip when you do your preparation. So nowadays this feather design we don't recommend much, because the amount of enamel at the incisal tip is going to be very minimal, right? When you see here, you can have the enamel at this point is going to be very minimal. Half of your enamel you are going to trim and you are going to give your restoration. So the restoration, when it comes to the enamel part, is going to shrink down. So the strength of your restoration is going to come down. Similarly, the strength of your enamel is going to also, the natural tooth is also going to come down. So the feather edge design is not advocated in much of the situation unless it is going to be a very essential part or essential thing to be done. Okay, next design is going to be flat edge or butt joint design. So here what you do, you are going to involve the incisal tip. The full incisal tip is involved. You are going to cut flat of your incisal tip. So you can see here the incisal tip is involved. Rest of your preparation is similar to that of your window type. Only thing is you are going to involve the incisal. You are going to take it to the palatal aspect. Whereas in your window you are going to stop till this. Whereas in your feather you are going to involve till this. Okay, that's a difference. Okay, that's a flat edge or butt joint design. And the last design is overlapping design. So here you are going to take your restoration till the palatal aspect. You are going to involve little bit of palatal aspect also. So nowadays this is, you can see here, you are going to involve the palatal aspect also. So nowadays this design is more considered more beneficial and more advantageous in lot of way. I will be talking about in the preparation aspect when I am talking about. Okay, so this is the overlapping design. So with this I think I will be concluding. The attractive and predictable result, aesthetic result can be obtained through the creative initiative of the dentist and the coordination with the ceramic skill of your laboratory technician. Of course, as I told you, the skill of your dentist is very important. How you evaluate, how you decide on your treatment planning has to be implemented or has to be transferred to your technician, and the technician also should have the same mindset or mentality when he is working on the project or the treatment what you have undertaken. So it's going to be a joint hand between the technician and the dentist, so that you are going to give a predictable and successful restoration for your patient. So with this I complete the first part of the veneer. In the next part I will be talking about how the preparation has to be done, what is going to be the advantage and disadvantage compared to the different types of preparations. Thank you. Have a good day.